Hello everyone. Welcome to this lecture on post-operative pain, swelling, and wound management strategies. I am Major Arun, and today we will focus on evidence-based and emerging approaches that can help rehabilitation teams to optimize healing, mobility, and reduce hospital stay. This session highlights how physiotherapists or physical therapists play a critical role in bridging surgical recovery with function restoration. By the end of this lecture, you will understand why the early postoperative phase is critical and how timely interventions change the recovery trajectories. You will learn how pain, swelling, and wound are directly impact healing, mobility, and length of admission. We will also explore guideline based strategies to ensure that management choices are safe, effective, and evidence driven. And finally, we will see how clear patient education can empower individuals to adhere to home programs and detect complications early. Our goals are straightforward but vital. We aim to reduce complications and restore function using multimodal rehabilitation approach. As physical therapists, we must monitor patients carefully, protecting the healing tissue while introducing graded activity. And throughout the process, we must work in an interdisciplinary way using standardized assessment and documentation to improve safety and communication among the entire team. Pain is often the first and most distressing symptom after surgery. Therapeutic exercises should begin early, using pain free ranges to stimulate neuromodulatory pathways and prevent disuse. Cryotherapy is essential, helpful in the early phase. It reduces bleeding, swelling, and pain and may be continued longer if patients find relief. Gentle joint mobilization may be considered when pain arises from the joint restrictions, provided that the incision and repair should not be stressed. The transcutaneous electrical nerve stimulation, also called TENS, can be used as an adjunct to reduce pain and allow patient to participate in a better therapy. Some modalities are less effective. Routine ultrasound, for example, is not supported for postoperative pain relief and should not be used indiscriminately. Instead, mind body strategies like controlled breathing, relaxation techniques, and even simple yoga based techniques help to reduce anxiety and alter pain perception. Multimodal analgesia is always preferred, combining scheduled non opioid medications with physical and psychological strategies. And finally, the role of rehabilitation and enhanced recovery of the surgery pathway is key. These protocols integrate pain, swelling, control before and after surgery to reduce complication and auxiliary function. And finally, the role of rehabilitation and enhanced recovery after surgery pathway is key. These protocols integrate pain and swelling control before and after surgery to reduce complication and accelerate functional healing. Transcutaneous electrical nerve stimulation, or TENS, is applied with surface electrodes placed around the knee joint to modulate pain via gate control mechanism. Frequency and intensity should be set according to desired analgesic effect, ensuring patient comfort. Ultrasound therapy is applied
using coupling gel. With the transducer moved continuously in circular motion around the periarticular tissues. This promotes tissue healing, reduces inflammation, and enhances local circulation. Clinicians must avoid direct application over the graft, harvest site, or open wounds. Both modalities serve as adjuncts to rehabilitation, aiming to reduce pain and swelling while enabling earlier initiation of active therapy.
Swelling is more than just nuisance. It limits range of motion, increases pain, and delays rehabilitation. Therefore, the exercise programs must be designed carefully, avoiding prolonged dependent limb positioning, which worsens fluid accumulation. We use objective monitoring tools such as circumferential measurements or, when available, bioimpedance analysis to track edema accurately and adjust our approach.
Segmental bioelectrical impedance analysis is performed by attaching electrodes at standardized anatomical landmarks as shown in the images. A small electrical current is passed, measuring resistance and reactance to assess lean mass and fluid distribution. Post ACLR, segment BAA is valuable in monitoring quadriceps muscle atrophy, tracking recovery of muscle mass, and identifying asymmetry between the operated and non-operated limb. This data helps clinicians tailor strengthening protocols and objectively document rehabilitation progress. For accuracy, the test should be performed in a hydrated state, avoiding food or exercise 2 to 3 hours prior to measurement.
Several strategies can help control edema. First, the limb elevation above the heart promotes gravity assisted drainage. But we must ensure that the position also protects the wound. Compression garments or bandages can be very effective if they are correctly sized and applied with the right amount of pressure. Active muscle pumping, such as ankle pumps, quadriceps sets, and frequent ambulations, is simple, safe, and highly effective, as shown in the images. Finally, manual lymphatic drainage may be considered in some patients to improve comfort and motion, but it should be performed only by trained professionals.
Ankle pumps are performed in a supine or semi reclined position, with the patient rhythmically moving ankle into dorsiflexion and plantar flexion. The motion should be continuous, controlled, and pain free. This simple yet essential exercise enhances venous return, reduces postoperative swelling, and minimizes the risk of deep vein thrombosis. Clinically, it also promotes distal circulation and assists in lymphatic drainage. Patients should be encouraged to perform frequent sets throughout the day, and clinicians must ensure the ankle joint remains active without overstraining the surgical limb. Quadriceps setting is an isometric contraction exercise performed by tightening the thigh muscles while keeping the knee in full extension. The heel remains on the bed and the patient actively presses the back of the knee downward. This early activation prevents quadriceps inhibition caused by pain and swelling and plays a key role in regaining terminal extension. Clinically, quad sets improve circulation, enhance neuromuscular recruitment, and maintain muscle tone without stressing the graft. It is vital to cue patients to avoid compensatory hip lift and to focus on sustained high quality contractions.
Wound healing is influenced by mechanical stress. Excessive tension across incision can disrupt collagen alignment and increases the risk of scar widening or even wound dehiscence. In selected cases, kinesiological taping may be helped to reduce swelling by promoting superficial lymphatic flow, though evidence is mixed. During patellar mobilization, always use safe techniques and avoid stressing surgical repairs, applying gentle, graded movements within allowed limits, as depicted in the image.
Kinesiology taping or key taping for edema reduction employs the web method. Strips are cut into fan like segments anchored proximally near the lymphatic drainage site and applied with minimal stretch over the swollen area as shown in the images. The skin should be clean, dry, and free of oils before application. The tape gently lifts the skin, creating channels that facilitate interstitial fluid movement and reduce localized swelling. Clinically, this method supports edema management postoperatively without restricting mobility and may also provide proprioceptive feedback. Taping should be always complement, not replace. Standard swelling control methods such as cryotherapy and compression should be considered. Patellar mobilization is carried out with the patient in supine and knee extended. Using gentle manual pressure, the patella is mobilized superiorly, inferiorly, and laterally within pain-free range. This prevents postoperative adhesions, maintains mobility of the extensor mechanics, and reduces the stress and risk of anterior knee pain. Clinicians must assess tissue resistance carefully, ensuring movements remain controlled and do not provoke discomfort. This intervention also facilitates quadriceps activation by reducing reflexive inhibition caused by patellofemoral stiffness.
Wound care evolves through phases. In immediate phase, the focus is on pain and swelling control, protected motion, and maintaining sterile dressings. In the subacute phase, we progress mobility and strengthening, always monitoring scar tolerance and wound appearance. Simple exercises as shown in the image. In the functional phase, we target full restoration of activities while ensuring that the scar can tolerate increased loading. At every stage, progression must be guided by clinical milestones, not just time, to avoid overloading vulnerable healing tissues. Recognizing infection is essential. Signs such as increasing pain, spreading redness, or fever must trigger immediate medical review. When drains, sutures, or staples are still in place, movement should avoid creating shear forces across the wound, and all dressing changes must follow an antiseptic non-touch technique, sterile feed, clean gloves, and minimal handling of the wound itself. During rehabilitation, always stay vigilant for red flags. Pain that is clearly disproportionate to the expected healing timeline should raise suspicion of complication such as infection, compartmentation, or hardware failure. Sudden swelling, erythema, or cough pain may indicate deep vein thrombosis and requires urgent evaluation. And wound care dehiscence or necrosis, often signaled by sudden increased drainage or visible facial disruption, requires immediate surgical review. Patient education is an important as the intervention themselves. Provide patients with a simple home exercise program that includes clear safety checks and symptom tracking. Reinforce adherence to icing, compression, elevation, and safe wound care practices. Explain the risks of overloading, whether by excessive weight bearing or forced flexion, and teach patients the warning signs that require them to stop. And finally, encourage healthy sleep, good nutrition, and adherence to surgeon specific restrictions to support optimal healing. The strategies we have discussed today are supported by evidence from pain management guidelines, wound care protocols, and enhanced recovery pathways. Always align your practice with both current evidence and the specific instructions of your surgical team. For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.